If you hear your heart doing, that is not your heart being romantic or emotional. That is your heart just doing its job. All right? Just doing its job, pumping blood. Because the heart is an organ just to pump the blood and asking for coffee break. A patient came to the hospital one time and was like, "Hey, Dr. Chebe, I just want to tell you that somebody broke my heart. You know, the boy I was dating, he broke my heart." I was like, "Which chamber did he break?" And she started laughing. So the point is, the heart has its different functionalities, and today we are going to review it, the anatomy and the physiology of the heart. Most importantly, I need to make this clear that this video does not substitute for your lecture slides or for your lectures. No, this is just a review. I'm going to discuss about 50 questions, and these questions are just concepts because you can be asked questions around them. These are the questions that feature most in your college exams and also in your board exams. So you do well to take pen and paper and write down some of these questions, think about them, study them, so that if they bring you a question that's similar to that, you'll be able to, handle it. All right. Most importantly, I need you to pay more than usual attention because there are some critical importance things that you need to know about the heart. So I'm going to review the heart as we discuss. First, I need you to look at this diagram critically. This is the circulation of the heart. All right, because this blood pump, how blood enters the heart and leaves the heart. There are a lot of questions they ask based on this. Some questions will be like, okay, which part is more oxygen poor, which part is oxygen rich? And there's something very peculiar about the heart, about the pulmonary circulation that is not in that is different from the systemic circulation. For example, baseline information, systemic circulation, we know that the veins always take blood to the heart, right? And the veins always carry what? Deoxygenated blood. That's why it's always in green. And baseline information, we know that the artery takes blood away from the heart. And the heart carries what? Oxygenated blood. That is why it's always red. All right? Now, in the heart, there is a little anomaly. There's a little difference. That is where questions are always based, which I really want you to look at before we even get to the questions itself. All right? So if you look at the diagram proper, what do you see? This is the vena cava. First of all, you must know how to trace the movement of blood in and out of the heart. So this is the right part of the heart. If you can see my mouse pointer, this blood moves the vena cava, the inferior vena cava takes blood everywhere below the neck, goes to the right atrium. The superior vena cava takes from the head, goes to the right atrium. You see, everything enters the right atrium. No pressure, no stress. That's why we call the right atrium the receptionist of the heart. All right. So so the right atrium takes in blood here, deoxygenated blood. This is the tricuspid valve. I'll repeat it a lot of times. This is the tricuspid valve, which is one of the AV valves. So the blood moves from here to here. This is the right ventricle, then moves through the pulmonary trunk, bypassing the pulmonary valve. This is the pulmonary valve, and spreading into the two pulmonary arteries. Remember, artery takes blood out of the heart. So do you see? Artery now here is taking blood out of the heart to the lungs, and the blood is taking is what? Oxygen poor blood, deoxygenated blood. This is only where it happens to the body. You need to know this because in your exam they may give you a question, and I'll read out some things to you. But these are some of the questions they ask. All right, pay attention to that. Now the blood moves all the way from the right atrium to right AV valve, right ventricle, pulmonary valve. All right, this SL means semilunar valve. Now there are two types of valves that you need to know about. One is the semilunar valve. Another one is aortic valve, the semilunar valve and the AV valve, rather, atrioventricular valve. The semilunar valve is divided into two. One is aortic and the other one is the pulmonary. So this one here, is the pulmonary. The one I'm pointing right now is the pulmonary. That's what we have here. All right. Then the second one is aortic, found in the aorta. Now, the AV valve, that's atrioventricular valve, is divided into two, which is this here, which is the right AV valve, and this is the left AV valve. The right AV valve has three flaps or three cups. We call it what? Tricuspid. The left has two cups. We call it bicuspid. All right? Bicuspid. Another name for it is mitral valve. Very important that you know all the names. All right? Okay. Now, the blood enters here from the pulmonary artery. It goes here from the arteries to the arterioles, which is small arteries. Then to the capillary. Remember what the capillary is. This is the capillary of each organ mixing together. That's where blood comes together and exchanges its components. Take oxygen, give me carbon monoxide. Extremely important. All right. Now, from here, the blood enters the vein. You see? Vein take blood to the heart. So it's pulmonary vein. This is also an anomaly because veins are never high pressure. They are low pressure. all right, and they carry deoxygenated blood. But in this instance, the vein is carrying what? Oxygenated blood. You see? Back to the left atrium, this time around to the left part of the heart. The left atrium, look at it here, all right? Left atrium through the pulmonary veins. They will ask you, so the pulmonary veins are oxygen rich. Now we have from the left atrium, passes the left AV valve, which is known as bicuspid or mitral, to the left ventricle. The left ventricle is the one that now pops it to the aortic, bypass the aortic valve. And there's a high pressure here. That is why the left ventricle is, look at it, you see the musculature of the left ventricle? Very thick, like a gym bro. So this is gym bro, So that's the left ventricle, passes it to the aorta. Aorta now passes it to the arteries of each organ. This goes down to, the arterioles of each organ, and the organ takes what it needs, and the circulation continues. So this diagram is very important. Why is this diagram very important? Because it has pulmonary and systemic. Pulmonary, what? Systemic. You have to know that there are two, which is pulmonary and systemic. Very important. So here, I took time to also explain exactly what I am saying. All right? I took time to explain exactly what I'm saying to the last detail, how the starting point of the pulmonary circulation, which is the right ventricle, pulmonary arteries, then to the lungs. Then it returns through the pulmonary veins to the left atrium. Extremely important. So you need to remember that pulmonary arteries are unusual, which I have already described. Now, you need to know the location of the heart. You need to know the location of the heart. That's why this diagram is here for you, to know the location of the heart. Now, this part that is pointed to the left is the apex. And one thing you need to know is that the apex is what? Pointed to the left. The heart is positioned approximately to the left of the midline of the body. This is the apex, to the left. Remember this, all right? Then this part is the base. It contains all the big vessels, all right? Then covering it anteriorly is what? The mediastinum. The mediastinum. Then everything is now within the thoracic cage. Extremely important that we know this. Everything is within the thoracic cage. So, we've already discussed this heart orientation, but it's very important for you to know the size of the heart, that the size of the heart at any time in your life is your fist, approximately anyway, all right? So, and remember the apex of the heart, remember the base of the heart, because you may be given a diagram and they'll be pointing to it. They say, which area is this? This is the apex. Which area is this? This is the base, all right? Or they may just ask you, where is the apex pointing? To the left. Very important that you remember this information. Talking about the covering of the heart, it's extremely important for you to know about the pericardium. Pericardium, the same pericardium everywhere. If you go to the digestive system, the same pericardium, right? Forming the mesentery, the omentum, and all those things. Now, in terms of the heart, right, we call it, the heart, first of all, is enclosed within the pericardial region, all right? Pericardium, all right? Now, there is something we call the parietal. Okay, if this is the heart, there's a sheet that is covering the heart. This sheet is important because it's a double-walled sac, and it is extremely important for several. One of the reasons is because it helps the heart to protect the heart against any surrounding friction. So the heart cannot beat at its own, pace. And also it provides the heart space to expand during filling and resist excessive expansion of the heart chambers, right? When the heart chamber wants to expand too much, it stops it. Extremely important. And you have to know these 4 or 3. One is the fibrous pericardium, the parietal pericardium, the pericardial cavity, and the visceral pericardium. The parietal cavity is important because it contains what? The pericardial fluid. That fluid, if it's inflamed, we call it what? Pericarditis. A patient will come to the hospital and say, oh, doctor, I'm having pains in my chest, right? What do you do? What do you do? You take history from that patient, you examine that patient, and at the end of the day, if it's inflammation, you will know. All right? So inflammation of that fluid leads to pericarditis. Furthermore, you need to know where that fluid is found. It's found in between the parietal pericardium and the visceral pericardium. Now, some question may ask, what is the most external part? The external part is not the parietal pericardium, the most superficial part, because that parietal pericardium has a tough outer layer, which is called the fibrous pericardium. If you see an answer, ask a question asking you for the most external part, know that it is the fibrous what? Pericardium, which is enclosing the parietal. So what we have is the fibrous pericardium, the parietal pericardium, a space in between them, that is pericardial cavity where the fluid is found, then the visceral pericardium. That visceral pericardium continues with the first layer of the muscle of the heart, which we know epicardium. We'll discuss this as we go on. So this is the diagram for you to be able to understand properly. If you notice, you see, what do you see here? This is the parietal pericardium, right? This is the parietal layer of the serous pericardium. This is the fibrous part. So this is the fibrous part, the most external, as I mentioned initially. Then this is the what? the serous part, all right? Extremely important. Then, the visceral part is here, somewhere here, all right? Then this is the cavity, this is the cavity here, all right? And this is where the fluid is found. Extremely important. If you check this, you will understand what the fluid does, the space does. When you hit the heart, it will not compress. So it helps to, sustain friction. Now let's talk about the muscles of the heart, muscle layers. What do we have? We have the epicardium, as I mentioned initially, the myocardium and endocardium. Listen, this is the epicardium. This is remember, this is the visceral layer of the serous pericardium, right? The internal part. Now, this visceral layer continues with the epicardium. It's very important for you to know this thing is the same thing with the epicardium. Now, this is the myocardium. Myocardium is the major, I repeat, myocardium is the thickest layer, and it is the major functional muscular layer of the heart. It performs the actual work of the heart. They will ask you a question. Which one performs the actual work of the heart? It is the myocardium, right? It's thick, you understand? And sometimes it increases with proportionality. For example, if somebody has heart failure and it has to pump extra to push out, before you know it, it starts thickening. That's something we call hypertrophic myopathy, all right? But this is not pathology class. So, but I need you to understand this very, 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 very well. So this is the epicardium, this is the epicardium, and this is the myocardium, and this is the endocardium. These three is what you need. Now let's go into the heart. What do we have? We have the chambers of the heart. Remember, we have the two atria and the two ventricles. It's very important that you know this. The two atria and the two ventricles. A before V. So each atria come before each ventricle. All right? So the atria, two chambers of the heart that receives blood returning to the heart. Any blood that enters the heart must enter through the atrium. Any. And anyone that is leaving the heart must leave towards the ventricle. It's extremely important that you know this. And because of that, the ventricles, they push. So they are pressure. They are high pressure. All right? And they're always thicker. Right? And there's something we call an auricle. Auricle, ear-like appendages, right? In the atrium that increases the chamber's capacity. That's what we call the auricle. But the right name is the atrium. And there are grooves that separates the chambers. They are called what? Sulci. You understand? They are called sulci. And in this sulci, you see the coronary blood vessels. Now, what separates this septum, the ventricles itself, is known as what? The interventricular septum. Extremely important that you know this. So I've already discussed the base of the heart and the apex of the heart. So for pictorial purposes, this is the base of the heart. This place that contains all these great vessels. This is the base of the heart, all right? This is the posterior, this is anterior. Then this is the apex of the heart. You see, the apex of the heart is pointing to the left. That's how I know that this is anterior. Very important for you to know. Now let's talk about the valves. Let's talk about the valves. What do we want to know about the valves? We want to know about the aortic valve and the semilunar valves and the atrioventricular valves. Why do I keep mentioning the aortic? Semilunar valves and atrioventricular valves, right? The atrioventricular valves are divided into two. We have the tricuspid, which is on the right, and the mitral, or the bicuspid, which is on the left. I've mentioned it many times. All right. Now, the question that we ask you is, if there's a problem with the mitral valve, for example, where will blood flow backwards to? Remember, these valves they're like bouncers in the club. You know what bouncers are? The valves, think of them like bouncers in the club. They stop things from going backwards. All right. They stop regurgitation. So if you open and fluid moves from the atria to the ventricle, it closes up so that fluid from the ventricle will not go back to the atria because the ventricle has higher pressure. So it has the potential to push fluid backwards. That is what you must remember. All right. So they may ask you specific question like, the mitral valve, where does it regurgitate blood to if it has a problem? Or the valve, where does it regurgitate blood to? Mind you, the right AV valve, that is the tricuspid valve, is in between the right atrium and the right ventricle. So if it has a problem, it will regurgitate blood back to the right atrium. The same thing with the left, that's the mitral, or the mitral, whatever, pardon my accent, all right? Now, the mitral valve, if it has a problem, there will be a backflow of blood to where? The left atrium. The tricuspid is the right atrium, but this is the left atrium. That's what causes left-sided hypertension. Like if it's left-sided hypertension, for example, blood will flow back to the atrium, left atrium, then back into the lungs. Before you know it, you see the patient trying to gasp for breath. The patient will be suffocating. The patient will be breathing. You understand? In that case, you see that the patient is having pulmonary edema. But if it is the right valve that has a problem, the blood will flow back to the right atrium and back. It will push blood back into the systemic circulation. And what do you see? You will see JV, distended jugular venous pressure, or vein rather, not pressure. Distended jugular venous vein. You see it becomes distended. You can even measure it. That's how we check for right-sided hypertension. Also, you see the patient having a lot of edema, all right? A whole lot of edema in the body. But if it is left, it's always breathing because there is pulmonary congestion. That's really important. Now, there are some supporting structures that you must know, like the chordae tendineae, the papillary muscle. The chordae tendineae, the word tendineae is tendon. What does it? Tendon always connects bones to muscles, right? So what does the chordae tendineae connect? It connects the valve to a muscle. The valve to a muscle. If you say a valve as a bouncer, like a bone, B for B, so it connects the valve towards a muscle. That's why it's called chordae tendineae. Which muscle is that? Papillary muscle. And this is only found in atrioventricular valves, not the semilunar valves. Only in the atrioventricular valve. So all atrioventricular valves are connected towards the chordae tendineae, and the chordae tendineae is connected towards papillary muscle. This is information that you are not supposed to forget. You are not expected to forget. So if I want to use this as an illustrative aid, you see, this is the AV valve, you see, then this is the chordae tendineae, this is the chordae tendineae, this is the papillary muscle. You see how the chordae tendineae is connecting the AV valve to the papillary muscle? So that's the information you need. You must know this blood flow because they may give you questions that have arrows. You have to choose. Oh, where does oxygen poor blood enter? Vena cava to right atrium to tricuspid. Sing with it. Sing with it. Put it in your head. Through the tricuspid valve, through the pulmonary valve, through the lungs, pulmonary veins, to the left atrium, then through the mitral valve, then through the aortic valve. Like it becomes interesting if you are able to understand this properly. Remember, as I told you, anatomy is what? Location, location, location. In short, if I want to define it better, I'll say anatomy is what? Structure, structure, structure. And physiology is what? Function, function, function. So the semilunar valves is the pulmonary valve and the aortic valve. Remember, it's very, very important for you to know the names of these and also for you to know what they usually do. Like the pulmonary valve, it's very, very important for you to know that it prevents backflow of blood into the right ventricle during ventricular relaxation. Why? The aortic valve prevents backflow of blood into the left ventricle during ventricular relaxation. Extremely important for you to know these two. Extremely important. All right. So they prevent backflow into the ventricles. The AV valves prevent backflow into the atriums. Simple. Put it in your head like this. So anyway they set the question, you'll be able to know. Now let's talk about the valvular functions. Extremely important for you to know. All right. So there's ventricular relaxation, ventricular contraction, and there's passive mechanism. But the most important one that we need to concentrate on is the ventricular relaxation and ventricular contraction. You need to know these things. When the ventricles relax, right, what happens? Think about it. This is the ventricle. It relaxes. If it relaxes, pressure drops. Pressure drops. Why is pressure dropping? Why is it relaxing? It's relaxing because it wants to get filled. So for it to get filled from the back, it means it has to lock up the front. Ventricle relaxing, where is the back? The back is the atrium. So that means the AV valves we what? We open. That's how you think about it. The AV valves we what? We open so that blood will be able to pour from the atrium into the ventricle. And at that same moment, the semilunar valves are shut. You don't want to close the front. Rather, you don't want to open the front. You close it, hold it tight. So it will relax, and the AV valve will open, and blood will flow. Once the blood fills in, what happens? We move from ventricular relaxation to what? Ventricular contraction. In the ventricular contraction, what happens? Immediately it's filled in, the AV valves shut close. High pressure opens the semilunar valve. That pressure will push it across the semilunar valve. That is what we call ventricular contraction. Ventricular relaxation is known as diastole. Ventricular contraction is known as what? Systole. Extremely important for you to know. All this is done by pressure, right? All this is done by pressure. It's very, very important for you to know this information because they will ask you, how does these valves function? What leads to their functioning? It is pressure gradient. So as a recap, major blood vessels, if you look at the diagram, I want to use this diagram to explain what do we have here. This is the vena cava, pouring blood into the right atrium, passing the tricuspid, you see, passing into the ventricle. Then this is the right ventricle, all right? The right ventricle pours blood into where? The pulmonary, passes the pulmonary valve, pours the blood into the what? Pulmonary trunk. This is the pulmonary trunk. Now the pulmonary trunk will now spread the blood through the pulmonary artery, you see? Two pulmonary arteries. Now, when it's oxygenated, it comes back through the pulmonary vein. These are the four pulmonary vein. 1, 2, 3, 4. All right? They come back into the right atrium. This is the right atrium. rather into the left atrium. This is the left atrium. Then the blood will pass through the mitral valve or bicuspid valve into the left what? Ventricle. Then from the left ventricle, it will bypass the aortic valve into the aorta, and off it goes. All right? So you have to remember each and every one of these. Now, there is a question I saw one time that says, oh, if the left coronary artery is obstructed, what will it cause? Answer: severe myocardial infarction. That's what we call heart attack. All right? Because blood will not be able to get to major parts of the heart. Like where? Like the ventricles. Both ventricles, blood cannot get there. Because the left coronary supplies the ventricles, and ventricle is the most important. Most important. So the two ventricles, right? And left atrium and posterior wall of the left ventricle. All these things are supplied by the left coronary artery. So if there is a obstruction in it, severe myocardial infarction, you must not forget this. You must not forget this. When you talk about the right coronary supplies blood to the right atrium, right ventricle, and posterior portion of the interventricular septum. You understand? It divides into the right marginal branch, posterior interventricular branch. All these things supplies some parts of the heart, but the most important is the left coronary artery. Now let's compare the cardiac structure, muscle structure, with the skeletal muscle structure. In my last slide, my last video rather, I did the skeletal muscle, in depth. I need you to go back there and read it up, because if you understand it, you'll be able to understand the cardiac muscle. Why? Because they have things in common. They have things, similarities. Like what? Like striations. You may be asked, what are the similarities between the cardiac muscle and the skeletal muscle? They can even ask you, what's the difference? Think about it. Cardiac muscle is striated, just like the skeletal muscle. But the difference is that the cardiac muscle striation is what? Intercalated discs that join end to end. But skeletal muscle striations are alternating light dark bands, but they have striations in common. Very important. Also, the cardiac muscle undergoes the actin, myosin filament, troponin, tropomyosin complex, all these mechanisms, that's contracting mechanisms. They do exactly the same thing with the skeletal muscle. All right? And also, in the cardiac muscle, you see a lot of electrical gap junctions for cell-to-cell communication. And most importantly, the cardiac muscle has what we call autorhythmicity, meaning that it can contract with itself without any nervous stimulation, unlike the skeletal muscle that needs nervous stimulation to contract. All right? So the cardiac muscle keep contracting. That's why they say the cardiac muscle is involuntary, but the skeletal muscle is voluntary. And because the cardiac muscle contracts every time without rest, it's never fatigue. You understand? That is the reason for this, is because it has an abundant supply of mitochondria for aerobic metabolism. We will see other things. Some of those other things I want to talk about, I want us to see, is like the aerobic dependence. Cardiac muscle depends solely on aerobic respiration. Think about it. Imagine the heart not getting oxygen. That's where infarction comes. That's a problem. Before you know it, heart failure, and the person may die, But if the skeletal muscle doesn't get oxygen, what happens is you start running on anaerobic respiration. For example, when you are doing exercise and when you are running, you run for some time, the oxygen is low. It starts running on anaerobic respiration. That's why, skeletal muscle will start producing things like lactic acid. You understand? And those are lactic acid, acidosis will now cause what? Fatigue. You get tired. But the heart does not get tired because it uses exclusively aerobic respiration. It has an abundant mitochondria, abundant, right? And another beautiful thing about it is that it has different energy source. It must not use only glucose. No. Glucose is just about 35%. But the major things it uses is fatty acids, which is readily available, all right? And other substrates. So that's why it has so much endurance, unlike the skeletal muscle. Now let's talk about the conduction system of the heart. That's the conducting of the heart. You know what conducting is? Conducting, we all know, conducting supplies the oxygen, power, current, electricity in New York. All right. Yeah. So let's assume the SA node is like the conducting of the heart. It initiates that power. It supplies electricity to the entire heart. Right. That's why we call it what? Pacemaker. So it initiates heartbeats, right? And it's found in the right atrium near the entrance. I'll give you a diagram, you see, right? Now, after that, we have the internodal pathways. These internodal pathways, ways that the electric conduction follows, that the SA node gives out. After the internodal pathways, you go to the AV node, not valve node. So AV node, what does it do? It's like the stabilizer. It reduces the energy if it's too much. It increases the power if it's too low. It's extremely important. It's located in the interatrial septum. All right? Then the next thing is a bundle of His, which conducts the signal from the AV node into the what? Ventricles. Then we now have bundle branch fibers and the Purkinje fibers. Does it make sense? So this is the conduction pathway proper in such a way that you'll be able to understand it proper from this to this to this to this to this to this to this. Now, this is the diagram. Remember, this is supravenar cava, this is the aorta, this is pulmonary trunk. We know all this diagram. This is the base of the heart, this is the apex of the heart. Then they can give you a diagram like this and tell you to point where the SA node is, or they will put A here. You understand? They may put B here. Yeah, they may put C here. You know, stuff like that. Or they may be asking you chamber. So you need to know these 4 chambers. You need to know these vessels. This is the pulmonary trunk, this is the aorta, and this is the vein. The vein, which is the vena cava, all right? Now, if you look at it very well, we are concentrating on the conduction pathway. So the SA node here generates this power. The power goes to the AV node, is stabilized by the, this is the internodal pathways, you see? These internodal pathways. It's stabilized by the AV node, pew, to the bundle of his. Bundle of his now spreads it to the bundle branches. You see, these are the bundle branches. So it's extrememely important that, and then to the Purkinje fibers. So it's extremely important that you know this pathway and also know how to recognize them in a diagram. In case of if you see diagrams in your board exams, which is a mainstay, which is something that is constant. Now, when you're talking about the SA node, it's very important for you to know that, you know, so it's very unstable. That's why we have the AV node to help it. And, you know, it repeats every 0.8 seconds. Extremely important. This figure is important, like it has been asked a lot. Now, we talk about the sodium inflow, we talk about the threshold, the water repolarization. But all these things, I want you to understand it as we go on. Now, the beat of the heart is by the SA node, right? So it's 70 to 80 is normal. If you see your exam and they tell you the normal one, look for the range between 70 to 80. Very important. But this ectopic, the ones that are not from the SA node, like the AV node, is 40 to 50. So if anything happens to your SA node and the AV node takes over, it can only pump 40 to 50. So if the AV node takes over from the SA node, right? Then we have other ventricular node rates like the 20 to 40. That's what they beat. So the most normal one is the SA node, all right? Now, there's a question I saw that asking about the plateau. This plateau is very important. But before that, talk about the depolarization and the repolarization. What you need to know is, depolarization going up. What leads to it? Sodium channels, simple. Then repolarization, that's coming down. What causes it? Calcium, potassium, Ca and K. Repolarization. But the beautiful one is the plateau. Which one helps you to plateau? Slow calcium channels. Mind you, not just calcium channels, but slow calcium channels. It's very, very important. Now, there is all this depolarization and repolarization leads to, you know, heart rates, all right? Now, when the heart rate is too much, especially when it's greater than 100 beats per minute, we call it tachycardia. Remember that word, tachycardia. When it is too slow, low, like 60 beats per minute, we call it what? Bradycardia. This shows that probably that there's a blockage somewhere or other disorders, you know, or the cardiac output is bad, you know. Then we have premature contraction, but the one I'm interested in is the fibrillation. It's chaotic, uncoordinated contractions of the atria. You understand? Now, anything that is abnormal, any abnormal cardiac rhythm is called what? Arrhythmia. You understand? We can, when somebody is having severe arrhythmia, you can do a lot of things like ablation procedures. You can even use implant pacemakers and defibrillators. There are a lot of people walking around that has implants, all right? Now, if you look at this diagram very well, it's almost the same thing that we've discussed initially. Now, this is atrial depolarization, but this is ventricular depolarization, QRS complex, and this is ventricular repolarization. So in case of if they want to ask you a question in this format, they may be asking you, P wave is what? Remember, P wave is what? Atrial depolarization. This is it. Atrial depolarization. If they ask you about QRS complex, they are talking about ventricular what? Depolarization. Then if they are talking about what? T wave, they are talking about what? Ventricular repolarization. Extremely important for you to know. And what is diagnostic tool we usually use to check this? ECG. ECG is very, very important for us to be able to identify arrhythmias. So this is further highlight of the P wave, QR complex, and T wave. Remember what P wave stands for? It's depolarization. Remember what KRS complex stands for? Ventricular depolarization. Remember what T wave stands for? Ventricular what? Repolarization. That's the information. Now, there are some disorders. Despite the fact that this is not pathology, but we need to look at this, right? Because we've been discussing the normal. What about the abnormal? All right? So this is the abnormal. Now, if you look at this critically, what do you see? You see that this is the mitral valve prolapse. Mitral valve prolapse. This is the mitral valve here in the left. You see how it prolapses? It prolapses backwards. You see the arrow moving backwards? When it prolapses like this, what happens? This guy is like the door has spoiled. So this guy will now start what? Pushing blood backwards from the left ventricle to the left what? atrium, which is not supposed to be. This is what we call backflow or regurgitation. All right, that's what they were asking you. Now, when you talk about stenosis, we are talking about blockage. You see how this guy is completely blocked? Blood could not move from here to here. So when this place is blocked, that is what we call stenosis. You understand? And when it's stenosis, there becomes a whole lot of load backwards into the lungs. It's extremely important for you to know this. We have valvular incompetence. That is when the valve is not doing well. All right. Normal valve closes up like this, like this. This puts it's a little covered, like it's incompetent. Goes back and forth. So it's incompetence is inability of a valve to close properly, allowing blood to flow backward, thereby decreasing the efficiency of the heart as it pumps blood. The most important thing is just that you must know that mitral valve prolapse is very common, 1 in 40 people. Usually, a lot of people have chest pain. That's why if you have chest pain, you have to go to the clinic and get yourself tested. Now, when you talk about heart failure, despite the fact that I've mentioned some of the heart failure initially, we have the right ventricular heart failure, we have the left ventricular heart failure, I stated initially. All right? What happens in the right ventricular heart failure? This is usually when the right ventricle specifically fails to pump blood effectively. What will it do? It will back up blood. Where does the backup blood go? To the right atrium, then from there to the vena cava, from there to the systemic circulation. What does it lead to? Edema, systemic edema, liver enlargement, hepatomegaly, distended jugular veins, TJV, then ascites. Same thing with the left. But this time around, the left is pouring the fluid from the left ventricle backwards into the left atrium, then backwards into the pulmonary. When you talk about congestive heart failure, it's just when the heart is no longer able to pump. Listen, the truth of the matter is that what you need to know is that most of these organs, once they start having problems, they show not in their physiology, not in their anatomy, but in their physiology. Like the kidney, for example, kidney may not be paining someone. Someone comes to the hospital, is not urinating sufficiently, or is bringing out blood, and they examine the patient and they see the patient has a kidney problem, right? So it's from the functionality, because the kidney, for example, is supposed to filter blood. It's supposed to filter blood, anything like greater than 0.8. It's supposed to filter it. So if it doesn't, and you see it in the urine, then there's a problem. Or you're not producing enough urine. It should be producing urine. Very important for you to know. So the same thing with the heart, right? If the heart has a problem, it's in the functionality. So there are a lot of problems in the heart. It can be valve, that can cause heart failure. It can be valvular problems, it can be infarction, it can be hypertension, anything. Though we usually treat it with medications that will reduce the workload of the heart and improve contact. I mentioned this initially, but I'll mention it again. We have the ventricular filling, that's for cardiac cycle. It fills. That time it's filling, that is when it has, we call ventricular diastole. It opens up like this. And at that moment, let me recap what we discussed initially. As it opens up, what does it do? The semilunar valve are blocked. The AV valves are open. Blood pours into it. That's ventricular filling. After that, what happens? It contracts and pushes out blood. You understand? So isovolumetric contraction and ventricular ejection. So what happens is the valve closes at the other end and builds up pressure. You understand? Volume still remains the same thing. That's isovolumetric, normal volume. Then the next thing is you do ventricular ejection. The semilunar valves opens up, it pushes blood out. That's ventricular ejection. So ventricular filling, isovolumetric contraction, ventricular ejection, then isovolumetric relaxation. They will give you this thing in chain and tell you to point to which one follows which. Now, when you're talking about the volumes, it's very, very important for you to understand the different volume parameters, right? Ventricular volume parameters. First, we have the EDV, that's end diastolic volume. We have the second one, the end systolic volume. We have the stroke volume, and we have the cardiac output. You must know this for. Starting with the cardiac output. Cardiac output is the amount of blood that is ejected from each ventricle in 1 minute. In 1 minute. How do we do this? We multiply the stroke volume, that's the amount of blood ejected in the heart, by the heart rate. That's how we get the what? That's why we get the cardiac output. So the cardiac output is SV times HR, stroke times heart rate, and that is what I put down here. Very important for you to know, right? Approximately around 5 liters per minute. Now, how do you get stroke volume? Stroke volume is very simple. It's EDV minus ESV. So let's leave stroke volume. Let me define EDV and ESV. You must know this calculation because you could be asked this calculation in the exam. All right? The end diastolic volume is the amount of blood in the ventricle after filling. So the ventricle relaxes, it fills, then it shuts up. We measure the blood. Oh, it's 130. Okay. Then it contracts and pushes out. After pushing out, the remaining, that is the residual that is found, maybe around 60, is known as end systolic volume. So the stroke volume is how do you know what it pushed out? Just what it has before with what is remaining, which is EDV minus ESV, getting what stroke volume. And when you multiply that stroke volume by how many times it beats, it gives you what? Cardiac output, which is 5 liters. Now, what are some of the factors that are affecting stroke volume? What did I tell you stroke volume again is? If you can remember, pause this video, write it down on your paper, put it in the comment section. I want you to comment. Please feel free to comment. Always feel free to make comments. Feel free to click like. If you've not done that, click it right now, please. Also, subscribe if you've not subscribed, because there are a lot of videos I'm going to be making. If you're a college student or not, if you are a student preparing for NCLEX, if you are students preparing for USMLE, please do well to subscribe and click the notification box so that you receive more. Most importantly, please just leave a comment for me. I really need that comment. If the video is good, tell me it's good. If there's something you want me to improve on, tell me you want me to improve on something. If I'm being too fast, tell me. If I'm being too slow, tell me. I really need to communicate with you, all right? So that we know the videos to make and how to improve my videos, all right? Now, let's go back to stroke volume. Remember what stroke volume is? EDV minus ESV. End diastolic volume minus end systolic volume. We get the amount of blood in the heart. What affects the amount of the blood pushed out in the heart? What affects it? Think about it. 1, we have the preload. 2, we have the contractility and the afterload. These are 3 major things, and these are 3 things that you'll be asked in the exam. All right? According to Frank Starling, he says that the heart pumps what it receives. It pumps what it receives, meaning that when there's increased stretching of the cardiac muscle fibers, it leads to what? Greater what? Contraction. So that's when we are talking about preload. So preload is ventricular filling pressure before contraction. All right? Before it contracts. That's preload. Afterload is usually arterial blood pressure, right? That's increased the amount of fluid that's pushed out. You understand? So that's the resistance to the fluid that is being pushed out. Is known as what? Afterload. There are some things that can increase it and there are some things that can decrease it. When you're talking about contractility, you understand there are also things that increases contractility. Remember, contractility is force of contraction for a given preload, right? Things that can increase it and things that can reduce it, like calcium, like acidosis can reduce it, hypoxia can reduce it, some medications can reduce it. So, but what you need to know for your level is preload, contractility, and what? Afterload. Preload, ventricular filling pressure before contraction, contractility, force of contraction, afterload, resistance to what? Ejection. Extremely important. S1, S2, S1, S2, S1, S2. Systo, diastole, lob, diastole, lob, dop, diastole, lob, systo. Does it make sense? Lob, diastole, systo, diastole. You need to play this in your mind. Play with this. You need to know what caused the first heart sound. Remember, 2 heart sounds are produced. One is longer than the other. The S1 is longer than the S2. Lop. You know, when you hear this, your heart making this sound, you think your heart is being romantic. No, it's not being romantic. It's just doing its job. Now, when you come to the clinic, the hospital, the doctor or the nurse will take the stethoscope to auscultate your heart, to listen to these heart sounds, to know if it is abnormal or if it is normal, or is there something else I should hear, which is called what? Murmurs. All right? There are things that we call murmurs, but the most important one is S1 and S2. Now, we have some S3, S4 sometimes that we can see in some pathological conditions, even some normal conditions, physiological conditions. All right? But we are not going into them now. What we are interested in is the S1 and also the S2. So the S1 is caused by when the closure of the AV valves. That's S1. So when the AV valve close, you know, what happens? That's the mitral and the tricuspid. When they close, what happens? The beginning of ventricular what? Systole. The ventricle will contract. So in the S1, the AV valves closes. Closure of the AV valves leads to LOP. It's longer. Closure of the AV valves is the what? The first heart sound, S1. Ventricular systole. Now, for the second heart sound, ventricular diastole, is when the cerebellar valves closes. So this is what you need to know. Oh, S1, first heart sound, when AV valves what? Closes. S2, when AV valves for what? When SL, that's cerebellar valves, does what? Closes. All right? Extremely important for you to know this. Now, remember the heart gets blood from the coronary vessels, right? We'll still discuss it. The coronary vessels can be damaged, right? It can be endothelial damage, can be plaque formation, it can be blood flow obstruction, you know, a lot of things. And how does it manifest? Angina pectoris, that's heart pain. You understand? Sometimes complete blockage, you know, leading to myocardial infarction. And what are the risk factors? What can lead to this? High LDL, cholesterol, low density lipoprotein cholesterol. Like that's why when you go to the hospital, they tell you, oh, your cholesterol is high. Oh, your cholesterol is low. Oh, your cholesterol is normal. All right? It has a range. Now, hypertension can also cause it, especially chronic. Smoking can cause it. Diabetes can cause it. Obesity can cause it. Sedentary lifestyle can cause it. That's why you need to be doing exercise every time. Don't just sit in one particular place. because the coronary, if it blocks, it becomes a problem. And remember, it is the left that is the one almost in danger, always, because it supplies the ventricles, part of the atrium. Now, the autonomic control of the heart rate is very, very important. We have the sympathetic and the parasympathetic. You don't need to know too much, right? The heart rate is usually influenced by the barometer. And what we say is the baroreceptors. Baroreceptors are there to what? To monitor blood pressure. Why the chemoreceptors are there to monitor the chemicals, like what? The gases and the pH. These are the two major things that affect heart rate. Other things could be emotion, stress, exercise, physical activity, body temperature. All these things could affect heart rate. But most importantly, how does the heart rate function? Which areas does it focus? It focuses on the sympathetic stimulation and the parasympathetic stimulation. What do you need to know? The sympathetic stimulation, right? It increases heart rate, like fight or flight, right? Short, it's 3 Fs: fight, flight, or fright. These responses are by the sympathetic. All right, and it's usually through the release of norepinephrine, which acts as a beta-1 adrenergic receptor in the heart. Norepinephrine, sympathetic. Norepinephrine, sympathetic. When you are talking about parasympathetic, is when you are rested. Your heart rate is low. All right. Parasympathetic nervous system decreases heart rate through the vagus nerve, specifically vagus nerve. So when you remember the vagus nerve, remember parasympathetic. When you remember norepinephrine, remember what? Sympathetic. Check it out, straight up. All right. But remember that in the urinary system and in the digestive system, this works opposite. Sympathetic is relaxed. Parasympathetic is where everything happens. Okay. So as a summary, you need to understand the key concepts, right? Because these key concepts will provide you information to comprehend cardiac physiology and pathophysiology when you do pathophysiology. What we are doing is physiology right now, all right? Now, you need to know the circulation pathways, the heart structure, the conducting system, the cardiac function. Extremely important, extremely important. These are the things, major things you need to know. There are more things. Now, when you talk about ECG interpretation, right, for this level, you may not really need to know it in depth, but I will advise you to go and take an ECG and look at it and understand it. All right? Because with ECG, you'll be able to understand arrhythmias. Arrhythmias kills a lot of people. Remember arrhythmias? Abnormal heart rhythms. Very, very important. If you look at this ECG, you see these are very, very abnormal, right? Missing intervals, missing waves, extra waves, AFib, all right? So it's very, very important for you to understand. And this is myocardial infarction. Did you see? Did you see the ST elevation? Did you see? Right? But this is normal. This is the normal ECG. So, we use this thing in the clinic. All right? So you'll be able to understand this. You'll be able to learn this. I'll prepare a video specifically. Somebody asked me to prepare a video specifically for ECG interpretation, which I will do very soon. All right? When you're talking about cardiac output regulation, you talk about the intrinsic regulation and the extrinsic regulation. Right? The intrinsic regulators are usually what is defined by the Frank-Starling, which is increased filling leads to stronger contraction. That's auto-regulation, all right? That's normal. You understand? The auto-regulation, is based on metabolic needs. The body needs this, body sends out this. It increases, flow because the body needs more blood in certain areas, all right? So these are inherent responses, all right? Now, when you're talking about extrinsic, there are factors that influence the cardiac output, all right? Now, one of them is the autonomic nervous system, which is sympathetic and parasympathetic that we discussed initially. Then there are a lot of hormones like the epinephrine, norepinephrine, and thyroid hormones. Also, the electrolytes like calcium, like potassium, and temperature. All these things are extrinsic factors that increases or decreases cardiac output. So, for your exam, things you need to master the important fundamentals. That's the structure, the relationship of the heart. Things we've discussed, like the chambers, the valves, locations and structures, and what they usually do. What do they connect? You have to trace the blood. You understand? Naming each structure and valve as you are going. All right. Also, the electrical pathway is very important. I want you to visualize the cardiac cycle, know what is involved, know how to calculate this and this. And by so doing, you'll be well prepared for your exam. All right. So we've treated a lot of questions actually during this discussion, even though I'm not pointing out each of them out individually, but I'll point some of them out right now. We just do as a recap, for this discourse. So some questions will be like asking you, which of the following carries the oxygen poor blood, or which of the following carries oxygen-rich blood? You should be able to know. That's the anomaly we are talking about, meaning that you need to know the exact architecture of the heart, the supply, the pulmonary units, and the systemic units, all right? Like if you look at this, you see that all this is oxygen poor blood. Like what? Like the vena cava, all right? The vena cava has even given it out. Like the pulmonary arteries, that's where they want to catch you, the pulmonary arteries. They carry oxygen poor blood. When you are talking about the one that carries oxygen rich blood, what are you looking at? This direction, the pulmonary veins. the aorta. All right, this carries oxygen-rich blood. You cannot forget this. Also, you need to know which belongs to the pulmonary unit and which belong to the systemic units. Pulmonary unit specifically, we are talking about the pulmonary arteries, right? And also the pulmonary veins. Those are the ones that belong to the pulmonary unit. But when you are talking about vena cava, the aorta, this belongs to the what? The systemic. So if you look at it properly, you see this is systemic, but this is the pulmonary. This is the pulmonary. All right? Very, very important for you to know this info. Another thing you need to know is the positioning of the heart. If you are asked a question like, oh, where is the heart folded in? What is the name of the space? That space is the pericardial cavity, right? If they're asking you, oh, where is the heart pointing to? It's pointing to the left, correct? To third to the left of the midline, correct? You have to know that. What is anterior? The mediastinum. You need to know that. You understand? You need to know where the apex is, where the base is. This is a recap. This is just a recap, all right? And we are looking at some of those questions, and trying to break them down to the smallest units. So these are the information you need to know about, the architecture of the heart and the musculature of the heart. How about if they're asking you about the fluid compartments of the heart, like the pericardial fluid, where is it found? Or they're asking you things like, which one is the most superficial? I've told you that the most superficial is what? Look at it. The fibrous what? Pericardium is the most superficial. After that, before you see the parietal layer, before you see the visceral layer, then in between the parietal layer and the visceral layer, what are you seeing? You are seeing the pericardial fluid. In between the visceral layer and the parietal layer, you are seeing the pericardial what? Fluid. It's very, very important for you to know this information. All right. Also, you need to know about the musculature of the heart. That's the myocardium. You understand? This is the myocardium. It's the one that performs the major function of the heart. Forget about the endocardium. Forget about the epicardium. The epicardium, remember, I told you, is attached to the visceral pericardium, right? Aha. So, but the endocardium is the epithelium of the heart, where the blood passes through. But the major musculature of the heart, the one that performs the work of the heart, is what? The myocardium. Also, the chambers, you must know the chambers. You understand? When they ask you which one is superior, you should know that the atrias are the superior. A before V, A before V, A before V. So the right atrium up, right ventricle down. The left atrium up, the left ventricle down. All right? So that's the information you need to know about the chambers of the heart. And also, you need to know about the interventricular sulcus. What is the interventricular sulcus? Remember, I told you that they are the shallow depressions seen on the external surface of the heart between the two ventricles. All right? Look at it. They are seen between the two ventricles. Extremely important. That's why they call it interventricular. Sulcus is shallow depression. Septum is a separation. Sulcus is shallow depression. Also, you need to know where the base and the apex is. You see, this area where the major vessels lead to and from is what? Is the base. That's why the major vessels are attached there. For real. Think about it. That's why they are attached there. It's the base. Why the apex is just this one below, this one down here, pointing to us, pointing to the left. All right. So if they ask you which one is above, tell them is where the major vessels attached, tell them is the base. Which one is pointing to the left? It is the apex. Okay, talking about the valves, what can we remember about the valves? We should be able to remember that the right AV valve regulates the opening between the right atrium and the right ventricle, right? That's what we have here. That's a tricuspid. They can call it tricuspid, they can call it right AV valve. The left AV valve, they can call it mitral or mitral, or they can call it bicuspid, all right? What does it do? It regulates blood flow between the left atrium and the right atrium. Left atrium and the left ventricle, sorry. Now, mind you, what is its function? What does it prevent? It's different from what does it do. It regulates these two openings of the left atrium and left ventricle, but it prevents backflow of blood into the left atrium, because they will ask you, oh, it prevents backflow of blood into where? Don't go and write the left ventricle. It's into the left atrium, backflow. So why the right? It prevents backflow of blood into the what? The right ventricle. Extremely important that you know this information. Extremely important. All right. And they may ask you, which one is oxygen poor? Which one does oxygen poor blood pass through? Can you tell me the answer? Pause this video, put the answer in the comment section. Please, everybody. Okay, fine. The oxygen poor blood passes through the what? The right AV and the what? The pulmonary valves. The right AV and the pulmonary valves. Remember very, very well, oxygen poor blood. If you notice, this is oxygen poor blood coming from the vena cava, enter the right AV. This is the right AV. It passes this valve. What valve is this? This is the right AV valve, right? Right AV. Mind you, right AV, or what? The tricuspid. Anyone they call it, you should remember. Now, it comes to the left ventricle and passes this valve. What is this valve? Pulmonary valve. before it enters the pulmonary trunk and then to the pulmonary arteries. All right. So when they're asking about oxygen poor blood comes from everywhere here to the lungs. You get it? Okay. Now let's talk about the caudate tendon and the papillary muscle. Look at this. I told you initially that they can ask you a question on this. This is the valves, right? These valves. The AV valves only are the ones that have the caudate tendon and the papillary. All right. So this is the caudate tendon, connects bone to what? To muscle. So if you assume that the valves are bones, so caudate tendon is a tendon that connects the bone, that is the valves, to what? The muscle. What's the name of the muscle? The papillary muscle. This is the muscle here. The papillary muscle. Extremely important that you know this. So the caudate tendon of the AV valves anchored to the what? To the papillary muscle. You can't forget this. Extremely important that you remember it. All right. And if they ask you what carries blood towards the lungs, you should always remember that it's the pulmonary trunk, the pulmonary artery. All right. Not the vein. The pulmonary trunk and the pulmonary artery. Also, there's this question that I was trying to discuss with you. Yes. Here, I was telling you about the valvular functions, the ventricular relaxation, the ventricular contraction, and others. Now, I told you that the opening and the closing of the heart valves is caused by what? By pressure gradients. Specifically, that's why it's here. If you notice, it's down here. It's really important that you remember this. The pressure-driven mechanism ensures one-way flow of blood through the heart, preventing the backflow and maintaining the efficiency of the cardiac pumping. Extremely important that you know this. All right? Pressure. It is not breathing. Your breathing does not cause any valve to open or close. It's not gravity at all. And it is not osmotic gradients. It's not valve contracting and relaxing. No, it is pressure. All right, pressure gradients. You can't forget this. Now, talking about coronary circulation, look at this information here. Extremely important. You see, an obstruction in the left coronary artery will cause the most severe myocardial infarction because it supplies the largest area of the muscle, including the critical left ventricle. Very, very important. Critical left ventricle. Very, very, very important. So where does it supply? It supplies the left ventricle, right? And two-thirds of the interventricular, in short, both ventricles and two-thirds of interventricular septum. So an obstruction in which of the following will cause the most severe myocardial infarction? It is left. LCA, left coronary artery. How about when we talk about similar? How does the cardiac muscle and the skeletal muscle, how do they resemble? The cardiac muscle, they are what? Both striated. I mentioned it. They are both what? Striated. Striated, but the only difference is that in cardiac muscle, the striation is what? Is intercalated disc. I mentioned it and it's right here on the board. Intercalated discs joined together end to end. But in the skeletal muscle, it is the alternating light dark band. I want you to go and see the video so that you'll be able to understand skeletal muscle very, very well. All right? So every other thing is a difference. That's what you should know. Every other thing is a difference. Now, you need to know the features of cardiac muscle. They have endurance a lot. A lot. They don't have the same endurance with the skeletal muscle. I'm telling you now. Remember it. Why? Because skeletal muscle, you run, you get tired, you get fatigued. Skeletal muscle uses aerobic and anaerobic respiration sometimes. It fatigues, lactic acid builds up, But the heart cannot, the cardiac muscle cannot fatigue at all because it doesn't use anaerobic. It's always aerobic dependent. And also it has a lot of mitochondria and a lot of different energy sources, not just glucose, right? Not just glycogen. It has fatty acid, and even other substrates. So they don't have the same endurance. Also, something that you have to know is that the gap junctions is where the electrical communication passes through. Nothing like neuromuscular junction, like in the skeletal muscle. Instead, it is what? Gap junction. That is the flow. All right. So if you ask a question about it, you should not start thinking things like desmosons, tight junction, all those things. No, those are skeletal. Please think about gap what? Junction. Think about what? Gap junction. Very important. Now, when you are talking about the pacemaker of the heart, what is pacemaker of the heart? AV node or SA node? I want you to put it down in the comment section. I'm not telling you the answer. Okay, I will tell you. It's the SA node. All right. So if you look at this is the conduction pathway. All right. At least you need to know the 6 of them. The first one is the SA node, where it's generated. Right. Then this is the internodal pathways to the AV node. All right. Then from the AV node to the bundle of His, from the bundle of His to what? The subendocardial branches. You see? Look at them. Subendocardial branches, right? So if they give you things like this and tell you, okay, which one is not part of the conducting system, you should be able to know it. And if they tell you which one is part of the conducting system, you should be able to know it. And you should be able to know the location. Where is the SA node found? It is here. It is here, just below the superior, the vena cava, in the right atrium, all right? So you should be able to know these things. You should know which one is not part of it. And also, you should know this pathway that I just mentioned. I had to put it out here so that you know which one moves to which one moves to which. Because they'll give you chain to pick which one is in the correct order. You must understand the information. You understand? You must know that this is SA node through the internodal pathway. Then it gives it to Uku, the AV node. The AV node gives it to Ku. Who does the AV node give it to? The AV bundles. That's the bundle of his. You see, these AV bundles. Then from there, it gives it to the left and the right bundle branch. Extremely important that you know this information. All right. So from the AV bundle, gives you some endocardial branches, then to the cardiomyocytes. Very, very important. What causes this pacemaker? What causes SA node potential? It's sodium. Please, it's sodium inflow. It's sodium inflow, not sodium outflow, not potassium, not calcium. It's sodium. All right. Extremely important for you to know. And the pacemaker, that's the SA node is 70 to 80 beats, right? Right. Now, when the pacemaker is damaged, like the SA node is damaged, when something happens to the first wife, I always call the SA node the first wife, and the AV node, I call it the side chick. So the side chick cannot produce as much as the first wife, all right? So what happens? It produces only 40 to 50. So if they ask you, oh, if the SA node has having problem, what does the AV node produce? 40 to 50. If the AV node have problem as the SA node, then we can talk about the other ectopic distance, like the 20 to 40 from the ventricles, all around it. We call it ectopic foci. Very important for you to know. Now, if you look at the cardiac action potential, what do we have here? We have that sodium channels open briefly, depolarizes the membrane to this, right? So depolarization is by sodium. Depolarization, that's going up, is sodium channels, right? Now, we plate you somewhere. Stops, stay like this, go like this way before it falls down. So that plate you is by its slow calcium. That's what they will ask you. Funny enough, you understand? They tell you that the plate you in the action potential of cardiac muscles results from what? Is it slow calcium or is it fast calcium or is it potassium or is it sodium? It is slow calcium. Plateau is slow calcium. Then when you're talking about repolarization, you start talking about calcium channels closing, potassium channels opening. Extremely important. Extremely important. So this calcium, where is it produced? Who provides it? It's the sarcoplasmic reticulum. Remember, it's sarcoplasmic reticulum provides it. Now, when you talk about cardiac arrhythmias, you talk about the tachycardia, you talk about bradycardia, you talk about premature contraction, you talk about fibrillation. Anything that is abnormal, we call it what? Arrhythmia. You have to go and mark this. You see, I have to mark it for you. Arrhythmia, anything that is abnormal, cardiac rhythm is what? Arrhythmia. I said it second time. It can actually be treated with medications that affect channels like calcium channels. Also, things like ablation, things like implants, defibrillators, I mentioned this initially. But mind you that any abnormality is known as what? Calcium, it's known as what? Arrhythmia. Now, that will lead us to this. Very, very important. You need to know what P wave is. Because if I ask what is atrial systole or what is atrial diastole, you should tell me. You should tell me. So this is P wave. You see, this represents atrial depolarization. I can ask you, or they can ask you in your body exam, NCLEX, USMLE, or whatever, they can ask you, atrial depolarization represents which, all right? They either can give you options or they can give you a graph. You should know that this is the P wave, all right? So this P wave, from where I'm pointing on the board right now, this P wave, this atrial depolarization. Atrial depolarization representing what? Atrial systole. So if they ask you atrial systole, that is P wave, P wave, P wave, P wave. And if they ask you ventricular depolarization, that is QRX. Look at it, QRS complex, QRS complex, QRS complex. That is what? Ventricular depolarization. Ventricular depolarization. It can also signify atrial repolarization. Now, this T wave here is what? Ventricular repolarization. Mind you, these are the major ones that comes out in your exam. All right? Atrial systole, atrial depolarization. So atrial systole, this is atrial systole, P wave. Atrial depolarization, still P wave, the same thing. The same thing. Don't get confused when they ask you those questions, all right? And when they're asking you about QRS complex, know that it's ventricular depolarization. T waves, know that it's ventricular repolarization. Okay, discussing a question, you can get one question or two questions from disorders, honestly, even though this is not pathology. In physiology, they ask a lot of pathology questions, but when you get to your pathology class, you'll be able to study more on pathology, or I will release a video on pathophysiology of the heart. very soon. All right. Now, let me just mention this succinctly. Valvular disorders, one of them is the mitral valve prolapse. It's one of the most common. Now, they can ask you a question like mitral valve prolapse causes blood to leak back to what? This one is common knowledge. It's simple knowledge. We know mitral valve, that's bicuspid valve, it's in the left, between the left atrium and the left ventricle. So if there's a problem, it will lead to what? So the regurgitation, that's backflow of blood into the left what? Atrium when the ventricle contracts. Blood will flow upwards into the left atrium. Very important for you to know. You understand? Now, we also need to know valvular functions. What happens when the left ventricle contracts? This one is a very, very important question. Think about it. If the left ventricle contracts, I've already discussed this, but this is a recap. If the left ventricle contracts, what happens? What happens to the sublunar valves? And what happens to the AV valves? So when the left ventricle contracts, the AV valve does what? Closes. It contracts, it closes, because it's pushing blood forward to the aorta and to the... So that means the sublunar valves will open. Sublunar valves will open. It will push blood. But the AV valves will what? Close. So on if it is left ventricle, they're asking about the left or the right ventricle, just know that the AV valves closes. That's the mitral valve or the tricuspid valve. But if they're asking you about the sublunar valves, they do what? They open, because they have to open for the blood that they are pushing from the ventricle to enter into them. So you should know when they're asking you about ventricular relaxation and ventricular contraction. It is opposite in relaxation. When its ventricle relaxes, you understand, the sublunar valve closes so that blood will not come back. All right. And what opens? The AV valve opens to pour blood into the ventricles. It's as simple as that. But when they contract, it's the opposite. You need to master this. You need to master this. Don't allow them confuse you in your exams. Good. This is something else you need to know about the loop and the dope. I sang with it initially. All right. So I'm not going to stress much on this right now. But know that when there is ventricular systole, closure of the AV valves, A, loop, A, loop, A, loop, A, loop, A, loop. All right? Then the sublunar is dope, the second one. So when the aortic sublunar valve closes, the blood bounces off it, it produces which sound? Dope, the second one. Dope, the second one. Very, very important. Very, very, very important. Usually this thing happens during ventricular what? Relaxation. You must be able to marry them together. And also you need to know this cardiac sequence, because they will tell you to arrange it. Remember that it starts from the ventricular filling, the isovolumetric contraction, the ventricular ejection, and the isovolumetric relaxation. You must know this sequence. You must know this sequence, because they can tell you what is the correct sequence of the events in the cardiac cycle. All right. Now let's see congestive heart failure. Very important. What are the things that congestive heart failure can cause? It can cause any of these. All right. If it's the right, you must make sure where they're asking you. If it's the right, it will lead to systemic edema. Why? Because when there's right congestion, it will push blood from the right ventricle to the right atrium, then to the vena cava. That's back into the systemic circulation. So the systemic circulation will be jam-packed. And what will it lead? It leads to systemic edema. All right. But when it is the left ventricular failure, what will it lead? It leads to pulmonary edema. Why? Because blood will back up to the left atrium, then into the left ventricle, from the left atrium into the lungs, leading to pulmonary edema. Also, it will lead to increase in the ejection fraction of the right ventricle. All right. But the most important thing you need to know is that congestion in the right ventricle, or congestive heart failure in the right ventricle, leads to what? Systemic edema, not pulmonary edema. Left ventricle leads to pulmonary edema. Right ventricle leads to systemic edema. Also, I need you to be able to make this calculation here, the calculation of the ventricular volumes. All right, you must know this. This is baseline. This is what they ask you, right? You need to know the EDV. The EDV, I told you, when the left ventricle is filled, that's EDV. When the right ventricle, when it ejects, any fluid that remains is the ESV. That's the end systolic volume. When you minus the two of them, what do you get? You get stroke volume. So EDV minus ESV is the stroke volume. All right. So when you are giving this calculation, you should be able to make that calculation. And when that the calculation is also asking you about what? About the heart rate. All right. It's very, very important for you to be able to also understand what the heart rate is. I told you it is between 70 to 80. Between 70, so if you see 70 is correct, if you see 80 is correct. All right. But make that calculation very, very well. You are not calculating the heart rate. The heart rate is just there. All right. What you are calculating is the stroke volume, the EDV, the ESV, or the cardiac output. So when you, for example, if the heart rate is 80, and when you do your calculation for the stroke volume, it's let's say it's 30. So what is your cardiac output? You multiply 30 by 80. It's as simple as that. 30 by 80. And sometimes they can ask you about the cardiac output. Remember what I told you cardiac output is? Cardiac output is the volume ejected by the ventricle in 1 minute. If that in 1 minute is not there, please, that can never be the answer. Extremely important. And what is stroke volume? Stroke volume is the amount ejected per beat. So the question is, what are the things that can increase stroke volume? What can increase stroke volume? You see, increase in preload, contractility, and afterload. All right. So increase in venous return can actually increase stroke volume. Extremely important. So other things I need you to go study the different diagram. I need you to look at the diagram of the heart. All right. For example, if I give you this diagram and I point here, you should know that this is the SA node. I point here, you should know that this is the AV node, right? This is bundle of his. This is the bundle branches. Very important. If I point here, you know that this is the tricuspid valve. This is bicuspid valve. Extremely important. What if I point this thing? You know that this is the what? The caudate tendon. Right? If I point the muzzle, it's the papillary muzzle. All right. What if this valve is pointed? See this valve? It's what? The aortic what? Valve. Sorry, not aortic. The pulmonary valve. Extremely important. Aortic valve is in the aorta. This is the pulmonary valve. Extremely important. Also know the chambers of the heart. Very, very important for you to know because it always comes out in all your exams. So, we've discussed a whole lot of questions. I need you to go down, look at this slide over, study it a lot, and go to your exam and do well in your exam. Please don't forget to like, don't forget to share, don't forget to comment, and don't forget to subscribe. Once again, I remember my humble self. I'm a professor in the college, and also I'm a medical doctor. See you in the next video.